Thank you so much.
Thank you.
Okay, good. Thank you. It's my pleasure to introduce Dr. Harzstark. Andrea is a medical oncologist at Kaiser, and she's going to talk today about immunotherapy for renal cell. Thank you, Andrea.
Hi, I want to thank the Kidney Cancer Association and Sandy Srinivasan for inviting me here to speak with you today about what I think is a really exciting topic, both in cancer therapy in general now, and especially exciting in kidney cancer. It's not going to move forward. Just plagued by technical difficulties today. Here we go. So our immune system does a very good job in recognizing things that are foreign and fighting them. That's its primary job. So that applies mostly to infections, but the immune system actually recognizes cancer as foreign as well. And if one were to say, well, if the immune system is so good, then why do people get cancer at all? Well, cancers are actually very, very smart. They evolve to evade immune recognition. Cancers actually affect immune function directly. And then if the immune cells need to get to the cancer for them to fight off the cancer, then you have to think about what the blood flow is directly to a cancer. And blood flow is very disorderly in cancers. As cancers grow, the blood vessels don't grow in a nice orderly way, the way that they do in the rest of your body. They twist and turn, and the supporting cells don't work. And so the immune cells can't actually always get to the cancer the way that they'd like to. We know that the immune system plays a particularly important role in kidney cancer. You heard about from Sandy that in many patients, if you remove the kidney itself, then the patient will do better. And that alone suggests that there may be an immune role in controlling kidney cancer in particular. There are also rare case reports of patients who have metastatic disease outside their kidney, but when you remove the kidney, the other areas of disease actually resolve. It's quite rare. I've only had it happen one time. But that in and of itself suggests that the immune system must play an important role in controlling the disease. You heard a lot from Sandy. Oh, that is not advancing up here, huh? It's advancing up here, but not up there. I'm going to keep talking while we're doing this. Maybe I'll switch spots with you so I can get the microphone. What will be up there is a timeline showing the development of all the different agents for RCC. So there are 8 therapies now for RCC. The 2 oldest are the immune therapies you heard some about from Sandy. So interferon and high-dose interleukin-2, they have largely been supplanted by the newer therapies, which target VEGF, which is a protein that is important for blood vessel growth, and then cell growth and metabolism through the mTOR inhibitors. There are still selected patients for which immune therapy still plays a role. That first slide, I titled this talk, What's New is New Again, because I think some of those therapies are still important, but the new immune therapies being developed are far more sophisticated. And so it's not just that what's old is being brought forth again. It's really something new and different this time.
I'm gonna have to do this.
Do what you need to do. So I'll touch just for a minute on those 2 older therapies. So interferon is a protein that your body makes itself when it's fighting off an infection. So those are called cytokines. So if you got the flu, your own immune cells would make interferon to help fight off that flu. It is, incidentally, what makes you feel really lousy when you get the flu. So if you get interferon, you feel really lousy like you have the flu. It is associated with a very modest response proportion in a large analysis of multiple studies of interferon. The number of patients who had significant shrinkage of their disease was about 12.5% compared to the control arms of the study, which were lots of different things depending on the study that they looked at, of about 1.5%. So very modest response proportions, but clearly some evidence of activity. And up until 2005, when we got our first new FDA-approved targeted therapies, this was really the standard that everything else was compared to, and really the only option for most patients.
Which one is it?
I believe it's this one, yeah. Hopefully I'll be able to show you, because this one slide, I really want to show them for Highdose IL2. Try. Don't go yet. Thank you. Okay, thank you so much. So Sandy gave you a lot of information about high-dose IL-2. I would certainly echo and agree with those comments. What I wanted to show you was this picture, because I think it's really dramatic, and didn't really talk about that part. So what you see here along this x-axis is the proportion of patients who are surviving, and along the y-axis is the survival in years, all the way out to 20 years here at the bottom. And what you can see is that the vast majority of patients are NR, are no response. That's about 80% of the patients who get high-dose IL-2, and these patients do not do well. There is a small proportion of patients, on the order of 7 to 8%, variable depending on which study you look at, who have a CR, a complete response. The disease essentially disappears on scans eventually. Those patients have, it's very hard to get an oncologist to use the word cure, but about as close to the word cure as you can get me to say. They have a long-term durable remission. Essentially, you don't see the disease come back in about 90% of those patients. So I would echo the sentiment that if you have a young, otherwise very healthy patient, you're a marathon runner, who has perhaps a minimal burden of disease, that this is still something that I think is worth thinking about. It is the only therapy that we have right now with the potential for cure. These are the two largest studies looking at high-dose interleukin-2, and again, durable responses in 7 to 8% of patients, and about 20% of patients who have either a partial or complete response. So the question is, if the immune system is so powerful, why hasn't immune therapy for kidney cancer in particular been more effective? Well, we know that there are changes in the immune environment that are activated by the cancer, caused by the cancer itself. I'm going to talk more about these things in particular. We know that the immune cells don't do a very good job showing the immune system what it needs to react to. They have to take pieces of the tumor proteins and present it to the immune system and say, hey, this is what you need to get excited about. And it doesn't do a good job doing that in cancer. And then we know that there are circulating proteins and immune cells in the tumor environment itself that actually suppress that immune function. VEGF probably sounds familiar to you, because most of the therapies that we have target VEGF, which is increased in kidney cancers. And so kidney cancer in particular is susceptible to those changes within the tumor microenvironment. This is not meant to be an exhaustive review of all the therapies out there for kidney cancer, but I wanted to show you this table because I think it's incredibly exciting to see what is currently in development in the field of immunotherapy. I'm going to focus on talking about PD-1 antibodies, CTLA-4 antibodies, which work in blockade of T-cell regulation, which are the main immune cells that are important in fighting cancer. There are other therapies that work on inhibiting the suppression of immune cells that tumors induce. And then there are therapies that work on T-cell activation, and then you heard a little bit about a dendritic cell activation. Dendritic cells are the cells that are responsible for presenting things to the immune system. So if we can present things to the immune system more effectively, then we can get more effective immune function. So I know this is a really complicated cartoon. Bear with me, I'm going to get you through it, but I think it's actually really useful for understanding kind of the framework for how we think about immune therapy. So on the right there in blue, you see the T cell. That's the main immune cell. On the left in peach there is the antigen presenting cell, or APC. That's the cell that presents things to the immune system to react to. For that reaction between the antigen presenting cell and the T cell to happen, we need not just an antigen, that little red diamond, to present to the immune or T cell. You need to have a couple of reactions to sort of stimulate that thing to happen. So you see that in black there, and then red and blue there. Now, you can imagine that if that reaction happened really, really well, you could get a very exuberant immune response. And so the immune system has a natural set of brakes that it puts on any immune reaction. That's that little green CTLA-4 here. So you have a natural brake so you don't have too exuberant an immune response. Well, if we wanted to increase your immune response, what if we could make CTLA-4 quiet down? So now there's no set of brakes there, so we can increase that immune response. And that is exactly what therapies that target CTLA-4 do. CTLA-4 is there to dampen the immune response, so they remove that dampening, so you get an increased immune response. There is a CTLA-4 targeted therapy available already, that's ipilimumab, which is FDA approved for melanoma. That has been tested in patients with metastatic kidney cancer. So at a higher dose in an early study, 5 of the 40 patients had a significant shrinkage of their disease. Now, that may not sound like much, but when you look at early studies, most often you're just looking for safety. You're not even looking for responses yet. So to see that many patients respond was actually really exciting. Now, you can imagine, I told you you're taking the brakes off the immune system to get a more exuberant immune response, that many of the toxicities would be immune toxicities then from the body. Its immune system is so excited that it's attacking everything in sight. So it's not quite that dramatic, but you can see immune toxicities from it. And so up to a third of patients in this study had immune toxicities that are consistent with this drug, things like rash from the immune cells attacking the skin, or diarrhea from it attacking the colon, or abnormal liver tests from it attacking the liver. It's worth knowing that there is an ongoing study of another CTLA-4 antibody called tremelimumab. I think I went to medical school just to learn how to pronounce these things, in combination with a standard therapy, sunitinib or Sutent. That's a phase 2-3 study. Last super complicated cartoon, but a similar idea here. So you have the T cell, again, the immune cell here in blue, and then this shows either antigen-presenting cells, the cells that present things to the immune system, or tumor cells down here in peach. Now, on the T cell is PD-1, and on the tumor cell or antigen-presenting cell is PD-L1. That L stands for ligand, which just means something that binds. So PD-1 and the thing that binds to it. So PD-1 is activated by PD-L1, and PD-1's job is to decrease the ability of T cells to kill cancer cells. So if you can block that receptor and its ligand from interacting, prevent those two things from interacting with an antibody, then you may be able to restore activity of those T cells that are specific to the tumor. So again, increasing your immune response is just a different set of receptors from CTLA-4 that do that. It's also known that kidney cancers that have PD-L1, so have that ligand expressed more, tend to behave more aggressively. There are multiple different PD-1 or PD-L1 inhibitors being evaluated, so I wanted to give you just a little bit of data out there on these, because these are probably, if you're reading the news about these things, these are the hot things in kidney cancer that everyone's reading about. So there was a dose-finding study, so again, a very early study, not to really look for response, just to look for safety, of a drug called MDX-1106 or nivolumab, which is a PD-L1 inhibitor in multiple different cancers. It was tested in 17 patients with kidney cancer, and 2 of those 17 in an early study responded. 1 patient had a response lasting a year and a half, and 7 more of those 17 had stable disease for at least 6 months. These were patients with advanced disease, so that was very significant activity. A similar drug, this is anti-PD-1, the other was anti-PD-L1, BMS 936558 was over 300 patients, including 34 with metastatic kidney cancer, and these patients were treated every 2 weeks for up to almost 2 years. It's worth knowing that the toxicities, again, were immune as expected and were serious in about 15% of patients. The most serious toxicity of this drug was lung toxicity, so again, the immune cells attacking lung tissue. But on that study, 10 of 34 patients had major tumor shrinkage, and another 9 patients had stable disease lasting at least 6 months. So 19 of those 34 patients derived very significant benefit from these drugs. And at the highest dose level that they checked, about 2/3 of patients had no progression of their disease for at least 6 months. one patient had, I think this is the most useful piece of information from this probably, that one of these patients had a partial response, so significant shrinkage of disease lasting for 3 years. And I told you the therapy only goes on for a little more than 2. And eventually that actually converted to a complete response where they could no longer see the disease on the scans at all, ongoing at a year at the time that they reported this data. So this tells you not just that the drug was able to effectively induce an immune response, but the drug was actually able to change the immune environment in that patient so that that response was ongoing and lasting. And that is kind of the holy grail of immune therapy, not just to induce an immune response, but to induce changes in that patient's immune system that can make that response long-lasting. And I promise I will not go through this table, but what I wanted to show you again was that there are a lot of these drugs in development. I think this, if somebody said to you, what is the most exciting area in kidney cancer right now? This is it. I won't touch on this too much because Sandy talked with you about a little bit about AGS-003, which is that vaccine approach that takes some of the patient's own tumor tissue and some of the immune cells from the patient and essentially generates an immune response and puts them back into the patient. This is combined with a standard therapy called sunitinib or Sutent. And in an early study, they saw survival without progressive cancer that were double what was expected. And so this was very promising and led to a phase 3 study, which is the study that you do to go for FDA approval of either sunitinib alone or sunitinib in combination with AGS-003. So this study is still enrolling, and I think this is a very promising approach. And then I want to say a little bit about combination therapy, dovetailing with some of what Sandy pointed out to you. So while you heard about how standard therapies really can't be combined well because of toxicity reasons, it appears that many of the immune therapies may be possible to combine with standard therapy, and that there is rationale, more importantly, for doing so. So we heard that the standard therapies mostly target VEGF, which is a protein that promotes blood vessel growth, and that protein is elevated in kidney cancer and is thought to suppress the immune system. This whole time, we've been telling ourselves, and everyone's been telling you, that most of the therapies we have work via targeting blood vessel growth. We think it's actually quite a bit more complicated than that, and that many of the effects of the standard therapies may actually be immune effects as well. So VEGF is elevated in kidney cancers and is thought to suppress the immune system. Well, if you can block the activity of VEGF, then you may be improving immune system function as well. So if you can combine a therapy that does that with one of these more sophisticated immune therapies, you may really be able to have a synergistic or more than additive effect. In addition, the standard cancer therapies may be able to reverse cancer-induced suppression of the immune system by reducing some of the cells that suppress the immune system. How's that for a double negative? Some of the cells that you see there. So there are multiple different combinations that are being looked at, and I'll just touch on these for a moment. So there's the AGS-003 that you heard about in combination with sunitinib. Then there's tremelimumab, which is one of those anti-CTLA-4 antibodies in combination with sunitinib. In an earlier study, they saw almost half of patients that had significant shrinkage of disease, although they did see some kidney toxicity in that study. And now there are multiple drugs, including ipilimumab, which is another one of those anti-CTLA-4 antibodies. They're trying a combination of that with one of the anti-PD-1 antibodies and multiple other drugs to look at whether these drugs can be combined safely. And then finally, you heard a little more from Sandy, but I'll just echo because I think this is the study that's furthest along at this point, is that peptide vaccine where you take the off-the-shelf vaccine of the 9 or 10 different cancer proteins and then combine them with cyclophosphamide and GM-CSF, which are drugs designed to stimulate the immune system. And in an early study, they saw a high response rate. Now, this study, I think I had just heard, just completed enrollment and is still, we're waiting for results on this as well. And then I wanted to spend just a minute talking about bone marrow transplant because people often ask about this. So the idea behind a bone marrow else's immune system will recognize your cancer as somebody else's immune system is going to fight, they're going to recognize everything in your body as foreign, and so you can have a lot of toxicity from that. So people have looked more at what they call a mini bone marrow transplant, where they don't completely eradicate your own immune system, but they give you a little bit of somebody else's and hope that it will start to fight the tumor, that the transplanted blood cells will essentially attack the cancer. So there have been a couple of small studies looking at this in kidney cancer, and the clinical outcomes have been very unimpressive, really very minimal shrinkage of disease in one study in a couple of patients, and in the other study, no patients with any shrinkage of disease. And more importantly, what they were looking for was evidence that the transplanted cells actually fight the cancer, which is called graft versus tumor effect, and there was no evidence of that at all. So this has essentially been abandoned in kidney cancer. So in conclusion, I'd like to say I think the immune system is quite powerful, and I think it can be modified both via our therapies and via changes in patients' own lives. You know, there was a study this year in the big oncology journal that looked at yoga in breast cancer survivors and showed that patients who did yoga had reduced levels of various inflammatory proteins, like the ones that I told you that we use for treatment of kidney cancer. Now, do I think there's something magic to yoga in particular? No. But I do actually, I've become much more of a believer in advising people that things like sleep and diet and exercise and stress reduction probably really do matter as we gain a greater understanding of our immune system, that I think those changes are probably important. Are they enough? Well, I think in a lot of cases probably not, but I do think that they may have an important impact. Existing therapies that target blood vessel growth may exert their benefits in part through the immune system, and so there's really hope for harnessing that in combination with some of the new therapies, and that multiple therapies that leverage the immune system are in development. So what is old and what is new may really be new again. Thank you.